I want to acknowledge that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples that includes the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, and the Métis Charter Community of the Lower Mainland region. And I am situated in an area called Mount Pleasant, which is at the mouth of the where the river used to end, and Kingsway used to be, where there was a berry and hunting pathway. So knowing where you are in the place that you are is important for us as we go towards truth and reconciliation, appreciating the land that you're on and where you are situated and who you are in that. Next slide. So I'm going to hand over to Dr. John Gill, who is the transplant academic lead and a professor of medicine at the University of British Columbia, and an active transplant researcher and clinician, to introduce Dr. Atul Humar and Dr. Deepali Kumar. Over to you, John.
Good morning. Thank you, Deirdre. Good morning, everybody, on a rainy Friday. It's a real treat for me to introduce my dear colleagues who really I've known in the Canadian transplant community almost for 25 years. But they really are international leaders in transplant infectious disease. So we should be very proud of their accomplishments. Today, they're going to give us a unique Canadian perspective on COVID. We all have COVID weary, but I think this is a moment to really celebrate the tremendous depth and I would say flexibility and nimbleness in leading not just us in Canada with regards to COVID, but internationally. I'll start with Dr. Atul Humar. Dr. Humar is professor in the Department of Medicine at the University of Toronto. He has many accolades, but he is the director of the multi-organ transplant program at UHN. Welcome, Atul. And then following Atul, or sharing this presentation, is his spouse, Deepali Kumar, or other way around. And Deepali is also professor of medicine at University of Toronto. She's a transplant infectious disease doctor. And if you think about them, Atul has really worked at the forefront of herpes virus and translational research. Deepali also has worked in various areas, but really more of a focus on vaccines. So this is a real treat for us to have them both attend. Guys, thank you very much. I don't want to take any more from your time. Welcome. I look forward to your presentation.
Thanks, John. Thank you very much, Dira and John, for those for the kind introduction, and thanks for having us both. What I'm going to do is I'm going to share my screen. Okay, so I believe we're in presentation mode now. So again, thanks very much for having both of us, and we're going to talk about COVID and transplantation, and tell you about some Canadian data that we've been working on. So these are the disclosures for both myself and Atul, and we will be discussing off-label use of anti-COVID medications and vaccines, and we'll be doing a little bit of tag team. So I'll talk and I'll hand it over to him and then back to myself. So with regard to the objectives, we're going to review COVID-19 and its management in transplantation. We'll discuss donor screening for COVID and discuss the implementation of strategies to improve vaccine responses. So let's just start off with the virus itself, just so that we're all on the same page. So SARS-CoV-2 is the virus that causes COVID. And this is an enveloped single-stranded RNA virus, and it's part of the coronavirus family. And we've had coronavirus for at least 100 to 200 years circulating in humans. And they're basically have established themselves as community coronaviruses, and they all have names and abbreviations. But we've also had these outbreak coronaviruses. So SARS-1 affected Toronto and China and other parts of the world in 2003. And MERS, which is the Middle East Respiratory Syndrome coronavirus, continues to affect people in the Middle East. And all these coronaviruses, they circulate in bats, but because bats don't often come into contact with humans, you normally need an intermediate host for the virus to pass on from bats to humans. So the intermediate host for SARS-1 was the civet, and for MERS, it's the camel. And for SARS-CoV-2, we're not 100% sure what it is. So this is the structure of the SARS virus. You can see the two things to remember are actually the spike protein and the nucleocapsid protein, because that's really what our antibody testing and so on is based on. So COVID is a systemic disease. We think of it as a respiratory virus, but really it can affect any organ. And in fact, the consequences, there are multiple consequences of COVID. So you can get strokes in young people, you can get clots and multiple areas of thrombosis. You can get acute kidney injury as well in up to 25%. And then various other things have been described, like skin conditions. And also now we're hearing a lot about long COVID. So, again, COVID, I think we all kind of know this from our readings and from what we see in the news also, that, there's two ways that COVID can go. You can have a mild disease, mild or asymptomatic disease, and build protective immunity. And protective immunity means you make anti-spike antibodies, you make CD4 and CD8 T cells. Or you can have this severe COVID, which means you have this immune dysregulation, you have lots of inflammation, cytokine storms, and you get pneumonitis, which can eventually result in death. So there are two ways that you can really go with COVID. So let me just talk about COVID and what we know about its management in transplantation. So transplant recipients are particularly vulnerable to COVID, and they can acquire COVID through three main ways. So you can get community acquisition, just like anybody else does. And this is really the vast majority of cases. You can get nosocomial acquisition, which is relatively, it's a low risk of acquiring COVID in hospitals, although I have to say it did happen at our center on the transplant ward, so not unheard of. But we are reducing the risk of nosocomial transmission by appropriate infection control, cohorting patients, having separate teams look after transplant patients and COVID patients. And then the third way that a transplant recipient can get COVID is through the donor. But again, and Atul will talk to you about this, we have strict donor screening in place. So what do we know about if a transplant patient does get COVID? Well, we know that patients have a greater risk of death. This is a study from 2020, just last year. It's from the UK. It's a population study of 17 million adults. They had 10,000 deaths. And what you see here is that for transplant, so that's organ transplant here, the risk of death was 2 to 5-fold compared to the rest of the population. And we knew this early on. And then subsequent studies told us that transplant patients had a more than 50% hospitalization rate, 15% overall mortality, much higher than the general population. And the risks in transplant patients for adverse outcomes were really older age and having more than 2 comorbidities in addition to their transplant. And then, there were a lot of papers that have been published in AJT and other journals looking at severity. And basically, they all show the same thing, that COVID-19 is more severe in transplant. This is out of the French group. Others from the US as well, and Spain have shown this. There is one study that looks at only critically ill solid organ transplant patients, and that actually showed that if once you become critically ill, that transplant patients have the same similar outcomes to non-transplant. So they're basically very similar to non-transplant once they're in the ICU, but before the ICU, they definitely have a greater risk of being hospitalized. So how are we treating these patients? How are we treating transplant patients who have COVID? So if they do come into the hospital, we're basically following the NIH treatment guidelines. We've had over 300 patients in our transplant program alone that have had COVID. And we've been treating them so far like most other non-transplant COVID patients. So if they are hospitalized and they require oxygen, they get remdesivir. If they're on increase, if their oxygenation requirement is increasing, we start dexamethasone. And if it's increasing further, we've been giving tocilizumab to the patients. And of course, some transplant patients have required ECMO and prolonged ICU stays. Now, I guess the issue is, in terms of transplant, it's unclear how effective these therapies really are. We're giving dexamethasone to people who are already on immunosuppression. We're giving tocilizumab to these patients as well. So, but we're not really sure. And there's very little data on how these immunomodulating therapies really impact. Do they really help in terms of reducing overall mortality? And then what about outpatients? So at least half of the patients that we see are outpatients with mild disease. And what are we doing with these patients? Well, I can tell you in our program, we're just doing supportive care. So we will keep a close eye on them. For some patients who seem to be particularly at risk, we'll send them O2 sat monitors to their homes, the finger oximeters. And we'll call them every day or every second day to see how they're doing. In the NIH guidelines, they do make a recommendation for monoclonal antibodies. So this is, the monoclonal antibodies are casirivimab and imdevimab, Cas and Im for short, and sotrovimab. Both of these monoclonal preparations are actually approved in Canada, but there are several implementation issues. So I'm personally not aware of any place, at least not in Ontario, we're not using these monoclonals, but maybe we should. If our patients are having 50% hospitalization rates, we should be trying to prevent that by using these monoclonals. They're certainly using them in the United States for transplant patients. So that's the overall management. What about immunosuppression? Well, most places will decrease their anti-metabolites. So that's your mycophenolate. So for example, these are just two examples of studies that have been published for outcomes in COVID-infected transplant patients. And what you can see is that in the study on the left, for a lot of patients, this particular center was decreasing or holding the anti-metabolite. And on the study on the right, this is from another center, they were actually reducing TAC doses, reducing TAC levels, and also adjusting their mycophenolate. So you can see there's all sorts of different adjustments going on with immunosuppression. I just want to talk very briefly about this study that's going on in Canada. So the study is a surveillance study. It's called SNO-TRAC, and this is an interesting abbreviation. So SNO-TRAC stands for Surveillance of Transplant Patients that are affected by COVID. And this is an initiative that we took with Canadian Blood Services. And through this initiative, so it's a multi-center study where different centers are giving data on their COVID-infected transplant patients. And we actually have more than 450 patients in this cohort. And I'll just show you the data on the Toronto cohort. So in the Toronto cohort, there are 160 patients that we've analyzed so far. And what you can see is that if you just look at some very basic outcomes like hospitalization, oxygen requirements, ICU, if you just want to focus even on the kidney patients, you can see that 2/3 of kidney patients in the Toronto cohort were hospitalized, and 20% went to the ICU, and 14 to 15% died. And this is very reflective of the overall cohort as well, where we had 15 to 16% deaths. And if you look at, again, what predicts these outcomes, what predicts death? Well, if you're older and if you have lots of comorbidities, that's what predicts death. So maybe, we should be taking these patients and giving them monoclonal antibodies early on when they are outpatients. And I think that's kind of where we need to go. So just, a bit of science, because it's always interesting to look at the science. We actually did some viral load testing in our transplant patients. And what the graph on the left shows you is how long the virus stays detectable in nasopharyngeal swabs. And you can see that by about day 11 to 15, let's say out to about day 20, there's very few patients left with a positive detectable swab. And, we don't know if this virus is still infectious at this time, but this is what we're seeing in terms of shedding. But of course, there are a few patients that are shedding for a long time. So on the graph on the right shows that, there's this one patient 001 that shed for more than 40 days, and we just stopped checking him after that. He may have shed for much longer. So prolonged shedding is observed in some patients. And then what about antibodies once people are infected? So the graph on the left is individual patients. Each line is an individual patient, and on the top is anti-spike antibodies, and on the bottom is anti-nuclear protein. And what you can see is that most patients will actually form antibody by day 14 to 20. And and by day 30 on the right here, 90% of patients will be anti-RBD positive, so anti-spike positive, and 77% will be anti-NP positive. I think the anti-spike assay is just a little bit more sensitive in picking up antibody than the nuclear protein assay. So, and who does not make antibody? Well, it's people who are taking a lot of prednisone, a lot of mycophenolate, and then lung transplants don't seem to make antibodies. But most kidney transplant patients will make antibody. And then just lastly, what about T cells? Just for interest, it turns out that the majority of transplant patients, if you look at the graph on the left, the majority of transplant patients will make spike-specific nucleocapsid-specific T cells. And most of the T cells are skewed towards a CD4 positive phenotype. And if you look on the right, most of the cytokines that are being produced by these CD4 T cells are interferon gamma and IL-2. So you do get these nice robust responses in transplant patients, as you do in the general population. So with that, I will turn it over to Atul, who will talk to you about screening and how to conduct transplant during a pandemic.
Thank you. Thanks, Deepali. So next slide. Next slide, Deepali.
Yeah, there might be a bit of a delay.
So,
hopefully you can see it.
I think all of us were taken by surprise at the rapidity at which the pandemic changed our lives, and it certainly changed transplantation in Canada. And what we saw in the first wave of the pandemic, this was about a year and a half ago now, was that there was a very drastic drop in transplant activity all across the country. And it was actually a combination of both deceased donor transplantation and a very significant hit for living donor transplantation. And I think at that point, all the transplant programs, not just in Canada, but across the world, were learning how to do transplantation in the midst of a pandemic. And this is adapted on, we had published a kind of global perspective in AJT on how transplant programs might approach transplantation in the midst of a pandemic. And so what we did in Toronto was we actually had 3 separate areas where we were looking after transplant patients. So we segregated the whole fresh transplant side. So we had fresh transplants in ICU and ACU as a separate area from COVID, and we had a separate fresh transplant ward. And then we had a separate COVID transplant ward, so just an area with COVID patients, and it was transplant and other COVID patients as well, but they were looked after by a separate team there as well. So they weren't looked after by the same people looking after the fresh transplant patients. And then we had another separate area because, of course, transplant patients get admitted with all sorts of problems, including fever for many other reasons. And we had them admitted to yet another area. And if they did get diagnosed with COVID, they would then move to the COVID ward. And we thought, remember, this was all pre-vaccination availability and stuff. So we thought this was a safer way to continue to try to carry out transplantation. And then the other key piece, I think, about safely carrying out transplantation was donor screening. And this was quickly adopted throughout Canada. And actually, I think Canada was a leader in adoption of donor screening, and certainly a little bit ahead of the United States at that time. Our rationale, and we worked very closely with the CBS and with CST, was that transmission was likely through lung and possibly intestinal transplantation, but we really didn't know what the other organs at that time. Some patients are viremic, and the incidence varies from study to study, but probably around 1%. But we thought viremic patients would still have detectable virus in the respiratory tract. So at that time, what we proposed was was a clinical screening, of course, and then 2 NATs, so an NP swab and a lower tract sample, which could either be an endotracheal aspirate or a BAL, and especially a BAL if the lungs were being considered for donation. We said there was really no role for testing of blood or urine, and no role really for antibody testing in donor screening. We also thought that all recipients pre-transplant should be screened, of course, clinically, but then also by a nasopharyngeal swab, because you don't want somebody who's incubating COVID to then expose them to immunosuppression at the time of transplant. So some of the other considerations around deceased donors who may have had COVID is that, of course, our recovery teams were quite concerned, and there was a risk to them going into all these other hospitals, some of which had COVID outbreaks, some of which the status was unknown, and then, of course, the risk to the recipients to transmission. We also weren't sure how to, at that time, approach deceased donors with a history of previous COVID. Some of the questions, and I'll go through this in a bit more detail, is how long since first diagnosis, what type of organ, and the differential risk of transmission, and then if the deceased donor is still PCR positive. Next slide. In terms of COVID transmissions, there's been, as far as I'm aware, there's been 3 well-documented transmissions in the literature, and these were all in lung transplant recipients. And these are 2 published cases, one by Daniel Call and his group, and then one at our center. The one at our center was lungs we had imported from the United States, and they had done 2 nasopharyngeal swabs and a CT scan of the chest, all of which were negative. And it turned out that the donor did have COVID and transmitted, and the BAL sample was positive in retrospect. So this really pushed us to recommend lower respiratory tract screening. And UNOS actually did adopt that. It was already common practice in Canada at that time, but UNOS did adopt that afterwards. Interestingly, in all the case reports, despite transmission to the lung recipients, there were no transmissions to the non-lung recipients from those donors. And indeed, many people have now reported, both in the United States and in Europe, use of organs and non-lung really from donors who are COVID positive. And this is just a report of 10 cases of successful kidney transplantation. And there are cases of liver and of heart transplantation as well reported in donors who have COVID positive. This is our protocol with TGLN in Ontario. We've taken a little bit more of a cautious approach. So what we've said is if you have if the donor has a new diagnosis of COVID in the last 21 days, so fresh COVID, we're still not using those organs. However, if they're beyond 21 days, so 21 to 90 or greater than 90, we're saying it's okay for the abdominal organs to go ahead, even if the donor is COVID positive. And then for the lungs, we have a little bit more stringent algorithms. We're not using the lungs if the donor is COVID positive. I have to say though, even though we approve these cases from a ID perspective, the teams are often still hesitant to retrieve and use organs from these donors. So I'm not sure how many we've successfully done using this strategy. Next slide. And then the other piece just is living donors. So what do you do with living donors with prior COVID? And we've certainly had many of these. So what our protocol here is we like the repeat NAT testing to be negative. We like the symptoms to be resolved. We also prefer if a greater than 21 days have passed since symptom onset. We have had a couple of donors where they're 90 days post symptom of COVID and they've had a very low positive PCR from an NP swab, and we have gone ahead with those live donors. And you also have to consider the organ function in those donors, and as well as any operative risk, because there is some data that early after COVID, these patients who undergo surgery are at higher operative risk. Next slide.
Okay, so I'm gonna now talk about vaccines. So you've heard about now COVID positive recipients and how we screen donors. I'm going to switch now to talking about vaccine and how we can prevent COVID. So COVID vaccines, we have a number of them in Canada. We have the 2 mRNA vaccines, and we were using the AstraZeneca ChAdOx vaccine as well. The Johnson & Johnson vaccine is approved in Canada, but has not been used because of production issues. So the vaccines, as you know, are highly efficacious. They do have side effects that have now come to light. So for example, the mRNA vaccines seem to have this myocarditis, pericarditis syndrome, which occurs mostly in the younger age group, mostly in males, and seems to occur more, at least in Ontario, with Moderna more than with Pfizer. And with the AstraZeneca vaccine, I'm sure you heard all about the vaccine-induced thromboses, the capillary leak syndromes, and also some neurologic issues like Guillain-Barré syndrome. So for transplant patients, clearly the mRNA vaccines are the recommended vaccines. So these vaccines are all based on the spike protein. And the spike protein is important because that's what the virus uses to attach to the host cell to get into and to fuse with it and to get inside the cell and then replicate. As you know, we now have all these variants circulating. So alpha, beta, gamma, and the Delta variant is the one that we hear the most about. And that's actually now become the predominant variant. And the way we classify these variants is by the changes in the spike gene. So it's the amino acid changes and the deletions that occur in spike that make these variants. And the variants, for the most part, are more transmissible. So all of these are fairly more transmissible than the original SARS strain was. Some of them cause more severe disease, like the alpha variant seemed to cause more severe disease, and same with the Delta variant. Pretty much all the variants will escape vaccine to different degrees. So the alpha variant was, the vaccine still remains somewhat effective, but with the Delta variant, which is what we hear more about now, the Pfizer vaccine is now down to anywhere from 42 to 66% effective, depending on the paper you read. And the Moderna vaccine is around 75% effective. So they have reduced in terms of their effectiveness in preventing infections, but I have to say that they still all remain highly effective in terms of preventing hospitalization and death in the general population. So just to differentiate actually being infected versus having severe disease. So the vaccines do remain effective for hospitalization and death. So COVID vaccines are recommended for our transplant patients, but I think the timing is very important. So this is taken from the CST guidance on COVID vaccines. So the CST guidance basically says to make sure that whenever we can, we administer vaccine in the pre-transplant setting. So while on dialysis for kidney patients, and if they haven't been able to receive vaccine in the pre-transplant setting, waiting for at least a couple of months after transplant to provide vaccine, so you get the best immune response. If transplant occurs between the first and second doses, give the second dose at more than 1 month after transplant. And if a patient has had COVID before, you just have to wait until symptom recovery and they're out of isolation before giving the COVID vaccine. And then making sure that everybody around the patient is vaccinated. So those are some general recommendations from CST. So, with that, a lot of our patients have now been vaccinated, and there's been a lot of science that's been produced in terms of how, in terms of the immune response to COVID vaccine. So I think just a little bit of a primer on how do we measure immune responses to COVID vaccine? There are 3 main ways. There's what we call binding antibodies. So these are antibodies that are protective against infection, but they don't necessarily bind to the site that interacts with the ACE2 receptor, which is what the virus uses to get into the cells. There's neutralizing antibodies, which is the type of antibody that actually prevents the virus from interacting with the ACE2 receptor. So these are the ones you really need, the functional antibodies. And then there's T cells. And T cells could be, CD4 T cells or CD8 T cells. These are research tests, and especially with antibodies, I'll just say that there are various commercial tests available for antibodies. A lot of patients will ask us, can we go get our antibodies measured? And it's really hard to know with those results what to do. First of all, I usually say not to bother getting your antibodies measured because we don't know what that means. But one thing to note is that, so there are lots of tests available. They all have different cutoffs. There's varying sensitivity and specificity, and not all are validated for vaccine immunity. And neutralizing antibody and T cells are just available in research labs. So what do we know about antibody responses in transplant patients and in other populations? So this is a slide that is taken from the CDC. And I really like this slide because what the CDC did was that they took a whole bunch of different studies that have been published in various populations like cancer, dialysis, transplant, and they looked at the percentage antibody response after 2 doses of mRNA vaccine. So each dot represents 1 study. And what you can see is that for dialysis patients, actually, most studies show that it's 80 to 100% positive antibody response. In fact, more like the 90 to 100% range. For transplants, though, you can see that the dots are much lower, and you're basically in the 30 to 40% range when it comes to percentage of patients with positive antibodies. And in the general population, so otherwise healthy people usually have 100% response. So these are just some selected vaccine studies in organ transplant patients, in kidney transplant. Some of them are specific to kidney transplant. And basically what you can see is that the response, the 2-dose response, ranges anywhere from 5%. This is for patients who are taking belatacept, all the way up to 54% in a US study. But mostly you'll find that the 2-dose response is in the 30% range. And these are all different antibody tests that have been done. So I think part of the variability is all the different types of tests that are performed. So I just want to tell you a little bit about our vaccine cohort. Again, just to put some Canadian science out there. So we have this what we call the Moderna vaccine cohort. These are transplant patients that all received 2 doses of Moderna vaccine. And you can see that they're all different types of transplants, and they're all on various immunosuppressives. So most are on triple immunosuppression. And what I'll show you here, just to orient you, so these are 127 patients, and this is their antibody levels. So on the left-hand side here. So these are in the pre-vaccination stage, nobody has antibody. After the first dose, only about 5% of patients developed any antibody. After the second dose, about 35% of patients developed antibody. And the green dots here are actually COVID-infected patients. So if you look at these, if you compare vaccine to infected patients and in terms of antibodies, in general, the infected patients tend to have higher antibody levels. So the median antibody in infected patients is about 100 units, whereas the median for the vaccinated patients is very, very low. So, and then again, for neutralization, you see a similar sort of thing, that very low neutralizing antibody responses. And neutralization actually tends to correlate very well with the RBD antibody. So, the other thing we've looked at in our cohort is T cells. And you can see that after 2 doses of vaccine, about half the patients are producing polyfunctional CD4 T cells that are, specific to SARS-CoV-2. Interestingly, T cells can form in the absence of antibody. So some of these patients had no antibody, that I showed you on the last slide, but they did produce T cells. So interestingly, they may not be protected against getting infection, but with T cells, they might actually be protected against getting severe disease. So I think that's something important to remember when we're reading all these studies. And then another interesting thing we found is that T cells with vaccination are still lower than with natural infection. So natural infection tends to actually give you better immunity overall in terms of antibodies and T cells, although we wouldn't want patients to go out and get infected. It's just interesting to see. So how well do these 2 doses work in real life? Well, we've seen a number of there's been a number of publications that have shown vaccine breakthroughs, and we've had we have about 50 patients now with vaccine breakthrough in Toronto alone. So, the first study was done in France. So this is the largest study. It's 55 patients who broke through vaccine. And you can see that 5% of them died. So you might think that, well, that's a little bit better than without vaccine, which is around 10 to 15%, but we don't have a real direct comparison here. There is some US data in terms of breakthroughs. So this is out of Dori Segev's group. These are 17 centers. So what he did was he took 17 centers who had 18,000 vaccinated transplants, and these centers saw a breakthrough of about 0.8%. So 0.8% of their patients got COVID, and in those, there was a 9% mortality. And so this cohort was compared to the general population breakthrough data. And interestingly, the rate of breakthrough in transplants is much, much higher. So it's about 80-fold higher rate of breakthrough in transplant versus the general population, and about a 485-fold greater hospitalization and death compared to the general population. And similarly, the UK has done a registry analysis. So these are registries that are they linked 4 different registries, and they found they had 48,000 transplant patients. And essentially, when they looked at the unvaccinated transplant patients versus those that had received 2 doses, they found that if these patients developed SARS-CoV-2, they had a 12.6% rate of death in unvaccinated versus 7.7% in the vaccinated. So, but I would say the 7.7% rate of in vaccinated is still very, very high if you look at it compared to the general population, which is around 1 to 2%. So how can we improve vaccine effectiveness or immunogenicity? Well, there's a number of ways we can give vaccine pre-transplant. I showed you that on dialysis, antibody responses are much better. We can modify immune suppression. So we could temporarily stop mycophenolate, but I think this has a lot of risk. And we should really not be doing this outside of clinical trials. We can give additional doses, and Atul will talk about that. We can use different vaccines. So if we had a vaccine that was not an mRNA or an adenovirus vector vaccine, we could potentially try that. And then some people are trying passive immunization with monoclonal antibodies, but I'm not sure about the practicality of that because these are injectable drugs and they don't last forever. So you would have to repeatedly be giving monoclonal antibodies to try to protect patients. And of course, we do need to do our regular public health strategies to make sure that there's good vaccine uptake in the population. This is just a slide to show you that mycophenolate does impact vaccine responses. So the percentage of people here, as your mycophenolate dose increases, the percentage of people with a positive antibody decreases. But again, as I mentioned, we would need some prospective studies for this. And so I'll turn it over to Atul to talk about the 3rd dose.
Okay, thanks. So this is the 3rd dose trial that we did. We took patients who got 2 doses of Moderna at 0 and 1 month, and then randomized them to receive a 3rd dose of Moderna or a 3rd dose of placebo. And you can see that it was double blind. So we had opaque tape on the syringes. So neither the person administering nor the patient nor the laboratory people knew what the assignment was. The primary outcome was defined a priori, and we said it was a RBD titer of greater than 100. And we chose that based on some animal data, as well as a large cohort study that was published in Nature that suggested that this might correlate with a 50% neutralization. And it also was the median of the RBD in infected transplant patients. So it is somewhat arbitrary, but we chose that as the cutoff. And then we looked at neutralization and T cells. So you can see we had 60 patients in each arm. We had a couple of dropouts, but not too many. One patient in the placebo arm developed COVID, and that patient had an RBD of 75 units per ml before they developed COVID, interestingly enough. So this was the characteristics of the patients. You can see that it was a relatively older cohort, and the time from transplant was in the 2 to 3 year range. It was a mix of organs, but included a reasonable number of kidney and kidney pancreas recipients, but also liver, heart, and lung transplant as well. We did do anti-NP testing in all of these patients, which was negative, and we did that to just confirm the absence of prior natural COVID infection. So NP, you'd expect to be positive with natural COVID infection. This just shows the immunosuppression, and really it was almost identical in the 2 arms, but everybody was mostly on tacrolimus, prednisone, and mycophenolate for the most part, and doses and levels were all very similar in the 2 arms. The next slide. So this is the primary outcome of the trial. So on the left is the anti-RBD titer in the placebo versus Moderna after the 3rd dose. And the 100 is the threshold of positivity. So you can see it was about 18% in the placebo arm and 55% in the Moderna arm. And on the right is just shows the pre to post intervention RBD titer. And you can see that in the Moderna group, it does go up nicely in many of the patients, and in the placebo group, it mostly goes either down, stays sideways, or in a few patients actually did still go up a little bit interestingly enough. Next slide. This is the neutralization data. So here, this is a surrogate virus neutralization assay, and anything above 30% neutralization is considered positive here. So basically, the number above positive in the Moderna group was 60% after the third dose versus 24% in the placebo group. So after 2 doses that the placebo group got. And then we just looked at T cell responses as well. And we have a lot of T cell data, but I'm just showing you here the CD4 T cell data. For the paper, the New England paper, we used a pretty robust outcome of a polyfunctional response. So we said it was cells that produced both interferon gamma and IL-2 in response to SARS-CoV-2 stimulation. And you can see this flow diagram is just one patient. So it's post second dose, they only had like a small number of positive cells. And you can see post third dose in the red bubble there, they had a whole bunch of, these are polyfunctional T cells. And then on the right is a summary of all the patients, and you can see the average. Again, we don't know the correlative protection, but you can see there's about a 5-fold difference in the number of SARS-CoV-2 specific CD4 T cells between the 2 arms. Next slide. The vaccine, the third dose, was quite well tolerated. There were no rejection episodes or graft dysfunction at 4 weeks, and now we have 3-month follow-up, and it's so far no rejection episodes or graft dysfunction. There was a little bit more local side effects in the Moderna group and a slightly more systemic side effects, but interestingly to note, there were also systemic side effects in the placebo group as well, just reflecting that this is a transplant population. Next slide. So the conclusions from this was that third dose provides a very substantial benefit with regards to all 3 endpoints that we looked at. It was well tolerated and should be provided to transplant and other similarly immunosuppressed patients. I think what was probably an academic highlight for my career was that, you know, we were sharing these data with various regulatory bodies even before the paper was published, including the FDA. And actually the director of the FDA was going back and forth with me on email for several weeks before the paper came out. And he actually timed the guidance. So the paper was released on August 11th, and he said he would time their guidance to coincide to come out right after the paper. So their guidance came out on August 12th, and the paper was released August 11th. So that was kind of a neat experience for us. I think there are some further research that needs to be done with third dose, including the timing. We used a 2-month interval. The issue of waning immunity. We didn't enroll any pediatric patients, so there really is no pediatric data out there as far as I know. We did have a mix of different organs, and although there wasn't much difference between the response between organs, the numbers were quite small. And then we also don't know in terms of variant and efficacy against protection of variants. So in closing, I think what we've sort of said is that COVID tends to be quite severe in transplant patients compared to non-transplant patients. The management is similar, although we don't have great data to guide us on management. We all, I think, practice reduction in immunosuppression where appropriate. We've kind of gone through donor screening, and then I think we've covered COVID vaccination in detail. With the primary takeaway is that 2 doses is really not sufficient in these patients, and they should really all get a third dose of COVID vaccine. Next slide. So with that, I think I want to thank John especially and all the others in the BC program who we worked very closely with over the years, and we're happy to answer any questions.
So thanks.
Someone's calling in with questions. Go ahead.
Yeah. No, I was going to say thank you very much for a really excellent presentation, and also showing us that Canadians can contribute to the world stage in a very humble and meaningful way as usual. So that's great. And, BC is working with Ontario on the on dialysis and non-dialysis patients and immunosuppressed patients with looking at some of these same things. So we're hoping to continue our collaboration across the plains. There's some discrepancy a little bit though, Deepali, because we saw Michelle Hladowic's data from Sunnybrook in the dialysis population, which did not show an 80% responsiveness in dialysis patients after first or second dose as well. And there's a increasing body of evidence that it is not quite as good as 80%, but that being said, I think it's still important that we learn a lot about this. Your thought about Moderna versus Pfizer and about mixed doses of vaccine, do you have any data within your...
Maybe I can talk about Moderna versus Pfizer, and then Deepali can talk about mixed. So we actually kind of intentionally chose Moderna for our CT, and the reason is that it does have a higher mRNA load in it. So it's a higher antigenic stimulus, about 100 versus 30. And the data, actually, there is other data that does support that Moderna is probably a little bit more immunogenic than Pfizer is. But I think if you've gotten 2 doses of Pfizer, we're still recommending that you just get the 3rd dose as Pfizer. Although if not available, you can get Moderna. I'll let Deepali comment on some of the mixing and matching.
Yeah, so I think, with regards to mixing and matching, really in Canada, the mixing and matching is mostly between mRNA vaccines. And, for the most part, the mRNA vaccines are very similar. Atul mentioned that the amount of antigen is more in Moderna, but in terms of the way that they're manufactured and so on, it's very similar. So, I would have no problem if somebody first received Moderna and then they received Pfizer or vice versa. With regards to, if they received AstraZeneca initially, I think at this point, the suggestion is to follow that up with an mRNA vaccine. One, because it seems that there's some preliminary data that the vector vaccines maybe don't work as well in the transplant setting as the mRNA vaccines do. So definitely if you've had, a vector vaccine initially, following that up with the mRNA vaccine would be very reasonable. I did want to comment a little bit on the dialysis question, because it is interesting, that I showed you the CDC data. They looked at a whole bunch of studies and they had those dots that looked like it was 80 to 100%. And yes, there's definitely some data coming out now that it may not be, as high as 80%. A lot of that depends on, there's a few factors. One is the timing of when you did the measurement. The other is the test that's used, because there is some variability in the antibody tests. And then, of course, the patient population, is it an older, what is the sort of the median age of these populations? So I think that kind of contributes to all the variability. I recently saw a 3rd dose study in dialysis as well. So I think all that data will need to be reviewed.
Yeah. There's a question in the chat from one of the attendees. What are your thoughts about mandatory COVID vaccination for patients pre-transplant as a policy?
Okay, yes, I can answer that question because we've been working on that actively for the last 2 weeks. So I actually strongly support that all patients who are being considered for listing should be vaccinated. And we've developed a policy which we've run through our program and have broad agreement. But there is concern from our legal department that this policy would not be enactable or fair or open us up to legislative problems from patients. So I'm hopeful we will adopt that policy. I think it's a controversial issue, but our whole reasoning for that is that patients, we have to ensure the best outcome possible post-transplant because it is a scarce resource that we're providing to the patient. And for deceased donors, at least, that resource could be better used elsewhere if the person's not willing to look after their organ after transplant. So So that was our approach to it. So, but I'd be interested to hear what you all are doing and what your approach is.
Yeah. First of all, Deepali and Atul, thank you very much. Very practical, evidence-based advice, and really actually hit probably a lot of the questions that the audience has had. We are debating this right now. I think that our discussion to date is there are requirements for vaccination for any organ transplant. We, as you guys do, go through the vaccination record, and we are yesterday in our kidney working group, we unanimously agreed among the kidney group. Now it's going to extend to the other organ groups through BC Transplant to add that as a requirement. That doesn't mean that if somebody actively refused to get the vaccine, that we wouldn't. So we haven't breached that subject yet, but the context of the discussion is we shouldn't have a separate discussion about COVID vaccination as we would with any other vaccine. So we're treating it, and we consider those a requirement and require patients to do those. So that's our position at this point in time. The data you guys show, I'm going to just ask one quick question from James Land here. James is asking, this is specific to Deepali, for the T-cell responses, Deepali, did you see any difference by immunosuppression like you did for the antibody responses? Was there any difference in the T-cell responses that you guys have examined? Because I know you guys have more T-cell data than you've shown.
Yeah, so, we have data on, 50 to 60 patients right now on T cells post-vaccination. And there's more data sort of that's going to be generated because this is part of a multi-center study now. In those 50 to 60 patients, we have not seen the impact of mycophenolate just yet. I think it's the sample size issue. We're certainly seeing trends, but we're not able to really show that impact. There's, in the 50 and 60 patients, it's also different types of transplants, and they're different at different times post-transplant as well. But we do see trends, for example, with mycophenolate.
I'm going to switch hats a little bit and ask you guys a bit of an ethical question. Given the difference in efficacy in the organ transplant population, the question of secondary vaccine trials, and maybe this is a good one for Deepali and Atul to comment sort of the ethics of that. I would view our population as really prime targets for secondary vaccine trials with novel vaccine vectors. Obviously, then you have to balance that against the fact that the disease could be more severe in our patient population. Your guys' thoughts about this this question, because I think it will be coming in terms of, if we hope to improve the response to the vaccine, how are we going to manage that? And your guys' thoughts about that?
Yeah, my own feeling is, I totally agree with you, John. I think this is a perfect population to do these types of studies in, because we saw even in our third dose study, the response rate is only 55%, so there's still a big chunk of people who have not responded, and we need to look at alternative strategies. And the other thing is our population are willing to do these they're willing to participate in these. Like, we had no problem. Patients got placebo, and they had no problem with that because they wanted to participate. They wanted to contribute to the science. So I think this is a great population to do these studies in.
Yeah, and I think in Canada we have an interesting additional, like the diversity of the system, the diversity of the patients' ethnic backgrounds, and the how many people we have in each of the provinces, I think will really lend itself to some excellent work. Yeah. And the mRNA technologies against other viruses that plague the transplant populations, like, are people now beginning to talk about that as well?
So I'll just comment on that. That's a great question. So, even before COVID, Moderna was developing an mRNA vaccine for CMV, and they still continue to develop that vaccine. There have been some sort of phase 1 and 2 studies with it. My only concern with mRNA vaccine, like now that we're learning more and more about it, is the durability of response. With COVID, we're now kind of seeing that you know, it may be from the variants, but you just, you know, you're not sure about this durability of response. And so I think that would kind of need to be sorted out, especially when we're looking at CMV vaccines and would the response remain durable, that sort of thing. So.
Yeah, and I guess the thing that you raised, which I've also just only recently learned, which I think the audience is really interested in, is this whole notion that Moderna and Pfizer are actually just different doses. Like it's a 3-to-1 ratio. So of course you're getting higher response with Moderna if you're getting that much more stimulus. So might not, if Pfizer given in a higher dose may be the same as Moderna.
You know,
right?
I think we're seeing more, like you see higher antibody responses. You may see higher antibody response, but I'm not sure the protection, you know, the clinical protection is that different. So there's that's another thing, you know, so you might see this big peak in antibody, but does that really translate into some sort of better protection?
Right. Yeah, and I think that's an important thing, the infection versus versus hospitalization, et cetera, is something I think the general public doesn't get their head around. And even within the medical profession, I think we're not so good at explaining the difference to patients. So I think, you know, this talk is certainly very helpful. I hope for the audience to be able to explain things better to patients, difference between getting infected and getting sick, because it does get mixed up a little bit. We are at bottom of the hour. I think it was an outstanding way to start the morning, complementary to last week's, where we're talking about some studies that we're trying to do in the non-dialysis and dialysis populations, looking at some of these responses and vaccine effectiveness across the 2 provinces. So really, thank you very much for all the work you've done and all the work you will continue to do. And hopefully we'll circle back and have more things to talk about in a positive way.
Thank you. Yeah, thank you for inviting us.
Thanks very much.
Guys, thank you very much, tremendously. Just before we close, I mean, I think one of the things that we should talk about as a chronic kidney disease and transplant population is a continuum, is how we advocate for our patients within the realities of a pandemic. I think this is a real opportunity when this is finally said and done for us to come together as one community and discuss how we have a national perspective on this, because we didn't get enough time here. But I think from a transplant perspective, and I think from a dialysis perspective, there are unique considerations in our patients, and how we advocate for those in the Canadian environment with our provincial setup, I think is a really important thing from a policy perspective to us to tackle. So I look forward to having you guys back and have some thoughts where Adir and I might be able to sort of, you know, when this is all said and done, have an appropriately timed conversation about how we take that forward. Thank you so much, you guys. Tremendous work, a real treat, and we're indebted. Thank you.
Thanks.
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 Bye.
Bye-bye.